Enteral Nutrition, Chapter 32, page number 407. Page number 407. If anyone is joining late, please help them out with the page number or the topic name. So first, in this 21st century, we have done remarkable inventions, innovations, and discovery with total parental nutrition, TPN. So, which means that with TPN, a lot of nutrition can be provided to the patients, okay, who may be either very extremely malnourished or unconscious, okay. In such patients, to maintain the nutrition, total parental nutrition can be given. It supplies all daily nutritional supplements requirements, and it can be used in hospital and even at home with the right procedure, the right techniques. TPN solutions are concentrated and they can cause thrombosis in the peripheral vein or even in the central venous catheter is usually required to give TPN, not through the regular IV therapy. Usually we go for the central line to give TPN. So coming to the physiology of malnourished patients, in moderate to severe malnourishment that affects anyone, it usually affects fat and protein turnover. Okay. And there is an increased, enhanced reliance on fat as energy resource. The body will start to use up the body fat as energy source. Okay. And subsequently, there will also be erosion in the protein source as well. Okay. First, the fats will be taken away from the body when you're malnourished. Then your protein stores, your muscle protein, okay, organ protein, these will be broken down, and then fat depletion takes place. Your fat will be complete, even the subcutaneous fat, okay, even that will be used up. There will be expansion of your extracellular fluid, okay, that is the fluid outside the cell, okay, that compartment will expand, and because of that there are high chances of edema, okay, water getting stored up here, and that leads to edema because extracellular compartment has increased in size, expansion has happened there. Okay, so more the space, more the capacity to hold water, okay, so that leads to edema. Hypernatremia, high levels of sodium in the blood, okay, that leads to hypernatremia. That is common among malnourished patients. Hypermetabolism, uh, too much, like as I mentioned, their own body fat, protein stores, glycogen stores, everything is broken down. So hypermetabolism, hypercatabolism takes place. Okay, what is catabolism? When the body breaks down its own food resources to meet the needs of the body. That is catabolism. So increased rate of breaking down the own body nutritional stores to meet the requirement. That is hypercatabolism that takes place. And when the patient is undergoing hypernatremia, uh, hypotonic solutions like 5% dextrox and all should not be given. Isotonic or hypertonic solutions can be allowed. Encourage the patient to drink more plain water if the patient can take something orally. In case of pediatric patients, weight for the height is the goal for the short-term period. The child has to maintain the weight for its given height or length. That is the short-term goal. Then after achieving the weight for the height, then long-term rehabilitation and physiotherapies will be given to catch up the growth with their peers. Then increased urinary nitrogen secretion. Too much of nitrogen will be excreted from the kidneys. Too much of nitrogen loss will be seen. Hyperglycemia, too much of glucose in the bloodstream, which is not being used up by the cells for energy, that is hyperglycemia. Immunosuppression, whoever is malnourished, their immunity will not function adequately. They are more prone to getting infectious diseases. So these are the major physiological changes that takes place during malnourishment. Coming to the nutritional requirement, any child who has malnourishment, and if you want to make sure the child has an adequate nutrient intake at least for 1 week or more, the we usually use holiday and Sagar formula to make sure that the child's based on the child's weight and height, adequate nutrition can be provided. Even in a well-nourished child, calorie intake, fluid requirements can be calculated using the holiday Sagar formula. Up to 10 kg, when the child has up to 10 kg of body weight, that is holiday Sagar formula. If the child comes under the 10 kg body weight, 100 kilocalories per kg is given. Okay. So maximum 1000 kilocalories you can give. If the child is above 10 kg, okay, 1000 kilocalories plus 50 kilocalories for each kg. Okay, so 1500 kilocalories has to be maintained. And if the child is about 20 kilocalories, 1500 kilocalories plus 20 kg per kg who is above which is over 20, that has to be maintained. Okay. However, in whichever formula you see, you will have to understand you should be very liberal with the supply of calories to maintain the to reach back to the weight and to promote growth in the child. So that is holiday Sagar formula. Many times in previous chapters, we have discussed this formula. Then the second way in how we can maintain the nutrient of the child is following the RDA given by ICMR. Even in the community setting or community health centers, RDA for age can be prescribed and that can be used. The recent RDA given by ICMR is in 2020, ICMR 2020 recommendation of RDA that is used. So carbohydrate, generally, when we are focusing on nutritional requirement in all sick children and even in well-nourished children, when it comes to carbohydrates, 50 to 60% of total calories should be supplied by carbohydrate in any hospital setting. Up to 15 to 30 gram per kg per day of glucose can be given if you are maintaining a IV therapy. And this is enough to prevent any significant protein catabolism. Oral supplements can also be started. Proteins, 10 to 15% of calories should be given, a child should get from protein. So it means 1.5 to 2 gram of protein per kg per day is usually given. In severe malnutrition, moderate to severe malnutrition, the protein intake can be much higher. It can be up to 3 to 4 grams per kg per day. And even in practice, when you adjust the calories, protein supply will be much more than what is required. But if you know that the protein supply that you're giving is low quality protein, then protein intake should not exceed more than 7 gram per kg per day. If it is a low quality protein, still more than 7 gram of protein per kg per day should not be given to the child. Children who suffer from hepatic diseases, that is liver diseases, formulations which are high in branched chain amino acids can be indicated. These are specific kind of protein, branched chain amino acids are specific kind of protein. This can be prescribed to children who have liver diseases as well. Then you have fat. 25 to 45% of calories can be given as fat. And in when you practice this, when you actually make a menu, 10 to 15% of total calories can be given from visible fat. And here coconut oil is chosen. Coconut oil has an advantage of it has MCT, medium chain triglycerides. And when you choose sunflower oil, it has an advantage of being a polyunsaturated fatty acid. Okay. So if you combine in a child's menu plan, if you include coconut oil and sunflower oil, both will be together, both can function well in the whole meal plan. And whenever it's possible, if the child is being breastfed, breast milk is good for the child. It has more fatty acids, essential fatty acids as well. Micronutrients like vitamins and minerals, the demand for vitamins and minerals increases when the child is malnourished or ill, okay, or there is an excessive loss because of any diseases. With a multivitamin supply, tablet supply, supplement supply, you can re-establish the micronutrient status as well. Coming to the route of admission, the policy that we should use is if the gut works, use it. If there is no issue with the gastrointestinal system of the patient, okay, you should use it. You should go for enteral feeding or oral feeding. If you know the GI system is not working at all, only then you have to go for parenteral nutrition. So the nutrition is can be enteral or parenteral. If the gut is working, you have to use it. If the GI system is working, you have to use it. So choose enteral nutrition, because when you choose enteral nutrition, it promotes your GI function. It stimulates hormones like enteroglucagon, gastrin. It can prevent and treat malnutrition when you choose enteral nutrition. Ensure early recovery. And in which all situations should you choose enteral nutrition over parenteral nutrition? Because whenever you know the physiology of the movement of GI system should be used in the patient, you have to use enteral nutrition. It is very simple to administer with very few complications when you choose enteral nutrition. And also it is 8 times less costly than parenteral nutrition. Cost factor also matters here. So these are the different routes of enteral nutrition. First route is oral nutrition. It's the best route of feeding, okay, through your mouth. Okay, when the child is being breastfed, sucking at the breast should always be encouraged in infants. Even if the milk supply is minimal, sucking will promote maturation of the gut, orofacial development, emotional satisfaction for mother and child both. Then you can go for feeding tubes. Feeding tubes can be nasogastric, orogastric. This is used for comatose patients, pre-term babies, kwashiorkor patients. The tube can extend below the pylorus as well. Pylorus is the end part of the uh, stomach. So this is how the nasogastric tube enters from the nostril, through the esophagus into the stomach. Then you have gastrostomy or jejunostomy. Ostomy means you make an opening here. You can see here an opening is made, ostomy is made, and through that a tube is inserted. Okay. So in gastrostomy also you have options: endoscopic, radiologic, and both gastrojejunostomy. Both can be done. Button gastrostomy, surgically placed gastrostomy. There are different types of options. These are different types of surgical options for gastrostomy. Okay. In gastrostomy, you make an opening directly into the stomach. And in jejunostomy, you make an opening directly where the jejunum is placed. Jejunum is the second part of your small intestine. This is duodenum, this C-shaped structure. This is duodenum, first part of small intestine. Then you have jejunum, then you have ileum. Okay, so jejunostomy, the opening is made into the second part of your small intestine. Okay, jejunum. Coming to the complications of different complications you see in um enteral feeding. Different systems will have different complications. When it comes to the GI tract, okay, gastrointestinal tract, gagging, stricture, esophagitis, gastritis, nausea, vomiting, abdominal cramps, these things can happen to a person who has enteral feeding. Mechanical, sometimes the tube which you use, okay, or technical and mechanical situations like the tube or the stoma, that's the opening that you have made, okay, that could undergo maintenance. There could be dislodgement, placement issue. Migrate, tube can migrate to somewhere else in the body. The place where tube is ending, there scar tissue can start to form. Aspiration, okay, these are the technical and mechanical complication. Metabolic complication, overload, dehydration, hyperglycemia, too much of glucose, too much hypoglycemia, too less of glucose, electrolyte imbalance, azotemia, hypercapnia, hyperphosphatemia, too much of phosphates in the blood, too much of calcium in the blood, vitamins and mineral deficiency. This can happen as a metabolic complication. Infections can also happen because of aspirational pneumonia can happen, septicemia. Sometimes if you are not giving good feeds, okay, if you're not giving hygienic feeds, that could also lead to gastroenteritis, septicemia. Then psychological, oral aversion, okay, but they will have a feeling of not to eat anything via mouth, okay, they will stop eating anything via mouth. That is oral aversion. Altered body self image, they will become so skinny. Usually they lose a lot of weight when you are on enteral feeding. You lose a lot of weight and your body image, self image varies. Okay. Coming to the commercial preparation that is available in India when it comes to parenteral and enteral use, you have a lot of amino acid infusions, 5%, 10%, plasmal solution, protein sterile fresheners, that is one brand, Vamin G, Aminocore 5%, Aminoven. Okay, these are the different types of protein based infusions, protein based IV infusions available. Then lipid infusions are also available, intralipids. 10% IV lipids are usually given. MCT, LCT, middle chain, uh, medium chain triglyceride. low chain triglyceride in 50-50 combination is used. Smoff lipid is one brand name. Brown preparations are also given in 500 to 50, 100 ml. Okay, 21% branch chain amino acids are provided through this brown preparation. These are parenteral preparation through central line. This is given. Enteral preparations, Pepti 2000. Okay, it's an elemental diet. Bonvit, Recupex, Pramilac, that has lactose. 2-cal, Tenolip, Glutamil. These are the different brand names of enteral preparations available in India. Lactose-free preparations are also available, like Tocal is lactose-free. Recupex is low lactose. It is not lactose-free. It has low contents of lactose. Tenolip is lactose-free. You have a Tenolip lactose-free variant as well. Then for kids, for children, Lactodex is available. It has lactose and dextrose. Okay, Lactodex. It has lactose and dextrose, lactose and glucose. For diarrhea, Lactodex for preterm baby and low birth baby is also available. Zero lac is a lactose-free formulation. Zero lac. Energex, it's a lactose-free but glucose-giving formulation. These are different types of formulations available in Indian market. In a table they have mentioned, you can check that last table.